So I'm going to switch gears on you a little bit and kind of talk a little bit more about state work. I see a lot of familiar faces, and so I invite any of them to jump in because they've helped create the work that I'm going to present to you. The goal here is to think about how we can solve some of these workforce shortages, where we need some statewide solutions. There's a vehicle that we've put forward. So when we started this work, it was more from a data perspective. We looked at the entire economy of the state. We looked at where we thought we would see the biggest labor shortages. Not a shocker to anybody in this room, but very quickly through that process, healthcare, manufacturing, and tech jobs really rose to the top as not just a projected number of job openings, but we actually did an analysis to look at job openings, look at how many people were coming out of our current pathways, smash that data together and start to actually look at, well, what are the gaps? As we did that, healthcare jumps off the page, 40,000 plus job vacancies by 2024. If we just keep doing what we're doing today, right? And we don't really change the equation around some of those pathways. The worker shortage issue is more than just an economic issue, right? It affects quality of patient care. The panel, and I'm sure the next panel, really laid out how and why workforce is so critical. But it also is an economic engine issue for the Commonwealth. So we brought together a variety of people who were potentially able to apply some pressure on some of the shortages and some of the bottlenecks that we know are true around some of those healthcare shortages. What we started with was putting together a collaborative. We didn't create a commission, we didn't draft an executive order. We actually wanted to build more of a private sector driven collaborative that was a little less formal than a traditional commission, so that we could really engage in some dialogue and conversation about workforce shortages. We kicked off a very large group, and the main mandate of this group is to think about those specific workforce shortages and some of the talent solutions as a result. We're partnering with many people on the collaborative who can bring that macroeconomic view to the table, but where our definition was very much around workforce. As a result, that collaborative was kicked off by the governor in January. Right now, my boss, Rosalind Acosta, who's the Secretary of Labor and Workforce, along with Dr. Mark Kerouac from Bay State, co-chair that group. It is made up of a variety of government secretaries, so Secretary Sutters, Secretary Pizer from Education, my secretary, and then the Economic Development Secretary. Because each of those houses own a little piece of some part of the workforce equation, right? We all know what Secretary Sutters owns, so I won't go into that. We have a lot of the workforce pipeline work. I heard Sharon talk about the great work Commonwealth Corporation does. Karen Schack is here from there. So we invest in a lot of workforce pipeline projects and initiatives. Secretary Pizer has brought a lot of the education leaders to the table to mimic a lot of what you heard from our community college panel this morning. And then, believe it or not, economic development owns a lot of the licensing agencies that affect some of the healthcare jobs in our Commonwealth. So we had a lot of different government players, plus private sector, plus education, plus payers. Right? That's another big piece. If you want to upskill CNAs, we have to start to look at how the payment structure affects that process versus just homegrown incentives in that process. So it may not be the perfect list, and it gets bigger. We do versions of this, and people say, hey, we want to be part of the team, and we bring people into the conversation. But our goal was to really leverage that power of multiple sectors to solve some of these bigger bottleneck questions, or at least try to solve them. We'll see how far we get over time. So if you go back to the data analysis I referenced before, when we started to zone in on healthcare, that 43,000 gap quickly materialized across three big buckets of job types, and I'll explain those in a little bit more detail. But the collaborative decided to take on workforce bottlenecks relative to nurses, which again, outside of Boston, is a really important issue, direct care, and behavioral health. So while behavioral health doesn't represent volume the way the other two do. The shortage of care and the pressure on that bottleneck is something that every healthcare leader we interviewed talked about, whether they provided direct behavioral health or not. So it is one of the emerging challenges, I think, for the Commonwealth, and we know this from the opioid crisis all the way through to, I tried to get my son a social worker and it took like a year, right? So the ability to get access to care is really, really significant. So the collaborative decided that we were going to have a wave one set of work, and it wasn't everything in healthcare, but it was some of the top areas of job shortages. So through that main collaborative in January, we broke the team down into 3 subgroups, focused in those 3 areas. We probably held 12 major focus groups with those subgroups. Again, many people in the room were part of that work. We had the luxury of a consulting firm doing this work pro bono through the Boston Consulting Group. And they conducted over 200 direct interviews with healthcare leaders, educators, payers, all the different stakeholders, government entities. That led into some additional qualitative and quantitative research on where some of these bottlenecks are and what other states have done about it. And finally, we used BCG and their ability to crunch data to think about, if we could solve some of these shortages, how would that affect the pipeline? So we put a lot of quantitative analysis around that. So after all of that hoopla and a lot of conversation, it boiled down into 6 main strategies that the Healthcare Collaborative literally voted on. So this is that huge group I showed you before, from the governor all the way through to some of the important healthcare leaders and other partners, said we want to focus on these 6 ideas. I'll spend the most time on the first 2. So after a lot of work with Department of Public Health, Health and Human Services, home care, mass senior care, healthcare alliance, all the different groups, we really looked at 2 big questions around direct care. One is, we have currently today a CNA certification process, and I heard someone reference this earlier, where we have people who actually want to get certified and they fail their certification tests. In some cases, 50% failure rates for different testing sites, mostly on the hands-on. And because of that process, we're losing people in that current pipeline who want to be CNAs, right? And we've got a lot of pressure in this market, as all of you know, where you can make the same wage in a job that isn't as hard, right? So the competition with the casinos and retail and other places was not lost on the group, but we've got a group of people who want to go through the process, and we're losing them in that process, right? So a lot of conversation about integrated technology and improved training, making it more interactive, making the hands-on piece more successful through the process. A lot of conversation about where CNAs are allowed to do their clinicals, what some of the regulatory restrictions are around that. So the first bucket is really around pulling apart that current CNA process and going back to look for efficiencies within that cycle, right? You could tell me more stories than I could tell you about where you've experienced that. We'll leave it there, and there's a group that we're going to set up to project manage and start to build some resources around implementing that. The second area is what you heard, I think, from the panel earlier. How do we build steps in the career ladder for someone to go from PCA to home health to CNA or some other version of that, from one care setting to another care setting? How do they go up the ladder to take the next step toward more of the mid-level healthcare roles? A lot of that work comes back to this question that PCAS started. How many people remember or know what that was, right? This was a state effort to look at competencies for direct care workers and to think about building more standards around that. So can we as a state do a better job of looking at those competencies and then certifying them and recognizing those certifications as people try to progress that ladder? So for right now, a home health person, for example, can't count some of their training towards CNA certification. Why? right? So how do we think about that in a more progressive, progression-oriented set of steps? And how do you tie that to incentives, right? Now we've got a lot of great employers who are trying to internally build those incentives in, but can you work with the payer community? Can you work with some of the new risk contracting? Can we work across settings so that the outcomes that are seen for a patient, the wage of that is shared from the doctor all the way through to the direct care worker, right? So those are some of the questions that have been raised in this working group, and our goal is to have this sometimes comfortable, sometimes uncomfortable conversation through this working group and around these issues. In my opinion, it doesn't erase or subtract from all of the amazing projects and works that people have set up across the state. It's really just trying to incentivize that and create more of a rationalized career ladder that recognizes those entry-level direct care roles. So again, I'm a workforce person, not a healthcare person. So our goal here is to bring the power of those players to the table to talk through some of these questions. Because for 20 years, we've been investing in CNA pathways, and we still have shortages, and we're still struggling with filling that gap. And so doing the same thing isn't going to get us to fill that 2024 shortage. So that's where this collaborative work is trying to aim its effort. And we decided we would take on 2 other important topics at the same time. So the second bucket, 3 and 4 here, the third strategy that the collaborative is thinking about is the career ladder for behavioral health. So I'm a former social worker, so the path, right, to get to those licensed positions, which are very defined. Some of the entry-level positions are well-defined, but that mid-level role that many of our behavioral health and other healthcare providers are offering is not as well defined. It's very hard to understand what you go to get a certificate for, or what you go back to your community college to train around. And we now have social workers and licensed professionals not working at the top of their license, and really there are tasks that need to be recodified and kind of filled in the middle of that behavioral health ladder. So how do you go from an opioid addiction counselor up to some of the licensed positions? Well, today, that's a huge, massive jump in terms of educational attainment for very little payback on the wage scale if you come out the other side with that license. So can we create more rungs in that ladder and do that with our educational partners and our behavioral health employers so that those mid-level competencies are recognized as part of the hiring process? So we have people like Gandera and partners and others who are doing that today, but we don't have a well-defined middle rung of that behavioral health ladder so that workers and people who want to come into that pipeline can navigate that in an easier way. The fourth piece of this, and I think it was Helen who was saying, you know, it just strikes me that there have to be other pathways to get to some of these jobs. So we've been doing a lot around apprenticeship, formal apprenticeship, and our goal in this 4th strategy is to build recognized apprenticeship models so people can work and learn at the same time while they're trying to get to the certification of some of these mid-level behavioral health pieces. We have some of that actually happening on the direct care side. A few people in the room who've been working on CNA apprenticeship and up, LPN and others. But the idea of doing this in the behavioral health space was something that the collaborative wanted to take on. Again, mostly because when you get to the highest end of that ladder, the pay compensation doesn't reward you in the same way as a doctor, and we need some other steps in a more economical way to get to the education criteria. So the last set of strategies were really around nursing, and these connect right up to a lot of the CNA pathway work that we were talking about the first 2. And there are 2 ideas that came from the collaborative here. The first one is Massachusetts is one of the few states that lacks a nursing center that really brings all things data and best practice into one place to better understand the future of nursing, improve diversity, improve retention, and improve pipelines. And so we are recommending that we do that, and we pull a council together, and we have some folks who want to help us be the convener of that council, and it would really encompass many of the members, some of whom are here today, who are stakeholders in the nursing pipeline arena. The last strategy, and this is my last slide, is really looking at some of the bottlenecks in the nursing pipeline that today keep us from moving as many students who actually apply and want to become nurses through that pipeline. And the big areas that the collaborative looked at were things like nursing faculty shortages, needing a more robust statewide clinical placement process. So we actually have a statewide clinical placement process, but not all employers engage in that. And there's some work we can do to do even more with that clinical placement piece. And then lastly, really defining that entry-level CNA home health job up to the ladder of the nursing pipeline, so that workers who start in one place can more easily migrate up to some of the nursing programs. So a lot on the education side in these two, and really thinking about how we're delivering that education and how we're maximizing clinical placements and faculty as part of the process. Again, nursing shortages have been around for a really long time, and we're looking at how can we do a few things differently to get to some of those solutions. So as I promised, I kind of switched gears on you, pulled the lens back to the 30,000 foot level, and we are hopeful that if we were able to put some of these strategies in place over the next 5 years, we'd have the ability to unlock conservatively anywhere from 4,000 new workers across those three streams up to 10,000. And again, we all know why, that's important to our economy. And so for the process and the work of the collaborative, we are in no way done. We have really just started. We kicked off in January, and we are looking to fundraise to build out staffing, management, and teams to implement each of those 6. So we are projecting kind of early startup costs to get those 6 off the ground at about $3.8 million. The public sector has come up with about half of that with reprogrammed staff and using things like the Workforce Competitiveness Trust Fund and other processes. But we're looking to some of our private sector stakeholders and other players on the collaborative to continue to fundraise. So we will end up sending a dedicated project manager to each of those 3 areas of work. This is a cat herding game. This is bringing lots of people in a room, a lot, frequently over time, to really build toward a set of more systematic changes. And so we're really looking for a team to take on that approach and to leverage the expertise of the folks we have, not only on the collaborative, but folks in the room, people who we haven't yet reached through the dialogue of the collaborative. So we're kind of in the last part of this quarter, moving toward fundraising. We actually set up an executive committee to begin to kick off that fundraising, and we're hoping to set up some implementation teams in the next month or so. So I'm going to stop there. Really want to say thank you to this group for letting us talk a little bit about the work here. It is hopefully a snowball, and again, it is not a formal commission, and so we're really looking to enthusiasts in the state who want to step up and help us get the work done. So I will stop there and happy to take any questions. And I have to call it, there's a bunch of members from the collaborative here, and if I forgot anything, if there's anything you want to add. All right.
Any questions for the Secretary?
One question.
NJ.
Next steps and timing.
So NJ led one of our subgroups and did a phenomenal job, and her question was about next steps and timing. So in September, we set up an executive committee. This month, next month, we have our co-chairs doing calls around fundraising, and Commonwealth Corporation and I are working on some early project management staff. Hopefully we can get that up and running by the end of the calendar year, to probably most likely start around the direct care work first. Some of the behavioral health work is directly tied to the healthcare bill that just came out, and so we don't want to get ahead of our skis. We want to collaborate with Health and Human Services and some of the work on the behavioral health side because there's a lot of new territory there. And then the Nursing Council, we're also fundraising around now. So a lot of this is in my lap. We lost our BCG team, so we're looking to co-opt other public sector staff who can help me from the project management side. Hi.
First of all, this was really interesting topic, so thank you.
Sure.
I'm curious about the direct care career pathways that you spoke of, and specifically some of the changes that seem kind of like no-brainers, the home health aid components that don't contribute to a CNA license, and then some of the work that's already been done by PCAS.
Right.
What have been some of the barriers to implementing some of those changes that seem so straightforward and impactful?
Right, so the question was, how do you think about the direct care ladder that is the first strategy relative to some of the work that's been done by PCAS and some very low-hanging fruit ideas that you could get off the ground? I think one thing we're hopeful for is to bring a lot of the voices together that are the consumers of some of those changes, the payer side, the hiring employer side, and the education side, to actually not duplicate PCAS, but to take that work and to work with the Department of Public Health and other groups, Red Cross, and a variety of folks were mentioned of who does that now, to talk through how that certification can be more streamlined and be more rationalized. So Leanne's sitting in the back there, right? She was the queen of the rollout of all of PCAS and helped us in our subgroup. No intention to duplicate that, but we don't recognize that in every education program today, and we don't necessarily tie it back to some of the, that's CNA certification bottleneck I was talking about earlier. So our hope is to facilitate that, and Leanne desperately wants to comment.
Yeah, because when we look at what PCAS brought us, it brought us an opportunity to transfer some of the knowledge into other professions, but also looking at the healthcare workforce trends that BLS is currently reporting on and what we heard today from the panel. What's interesting is that we see a huge increase in demand for the direct care workforce, the highest number of vacancies within that. That's partly due to the turnover that we see. I mean, and Helen mentioned most people leave within the 90 days. When we look at the projections between 2018 and 2028, what we're going to see is that there's a trend that's going to be shifting where there's going to be more demand for entry-level positions that require more education. And this brings us to the opportunity for upskilling these direct care workers through apprenticeship programs, ongoing training, because we're going to see as the workforce is shifting into higher needs that there will be this, we'll want to be able to look at how we would transfer all of these skills from what they might have learned, for example, in PCAS or other trainings into other programs. And so there's just this real shift, and I just encourage folks to continue to look at how we transfer knowledge and skills, and we continue to promote this upskilling and this career advancement as we go forward into like the next decade to be responsive. So, I mean, I think that was a great question, and it's just great.
So we've talked about taking that core, those like must-have skills, acknowledging those through certification, but I think it was Helen who also talked about modules around upskilling, and then can you tie those modules to increases in pay, expertise where people are, they got their base core certification, but then they have advanced, and to the degree to which more and more jobs are demanding that upskilling and education will be something we all need to be careful. You've got a whole bunch of educators out there too who need to understand kind of where is the prep going, right? Where are those skill requirements going? And that's our dialogue of trying to facilitate that conversation.